Hi, this is Courtney DiNardo. I'm from the University of Texas MD Anderson, and today I will be talking about treating patients with Enasidenib or Ivosidenib, managing differentiation syndrome, and other clinical pearls. IDH mutations occur in about 20% of patients with AML. They occur most frequently in patients with diploid or otherwise intermediate AML, and the older you are, the more likely you are to have an IDH mutation. About 12 to 15% of patients will have an IDH2 mutation, and about 8% of patients will have an IDH1 mutation. What's interesting about IDH mutations is that they lead to the accumulation of an oncometabolite called 2-HG. And this 2-HG essentially poisons the cells and leads to epigenetic changes and a block of normal cellular differentiation as part of the leukemia process. Ivosidenib, formerly AG120, is an investigational first-in-class, oral, potent, reversible, targeted inhibitor of the mutant IDH1 enzyme, and Enasidenib, formerly AG221, is an investigational first-in-class, oral, potent, reversible, targeted inhibitor of the IDH2 mutant enzyme, and both of these are now FDA approved for the treatment of our patients with relapsed refractory AML. Now, due to the mechanism of action of the mutant IDH inhibitors, we see evidence of differentiation activity with treatment in responding patients. And so this is not myelosuppressive or cytotoxic therapy, but here you can see in a patient over a 3-month period a differentiation and maturation of the leukemia blasts into their normal myeloid counterparts. And along the bottom, you can see that in this patient who had trisomy 8, you can see the trisomy 8 abnormal cytogenetics that were present in the blasts are now present in that patient's mature granulocytes, consistent with a true maturation. Those abnormal leukemia cells have now turned into mature granulocytes, but they maintain the original cytogenetic abnormalities that are not present in the lymphocyte lineage. And so in patients who have a profound maturation differentiation process, sometimes we can see a clinical event called differentiation syndrome. And this is an example of a patient who 2 weeks into therapy, this patient had a rising white cell count, a rising LDH. The patient was feeling quite fatigued, was developing shortness of breath and dyspnea, and a CT chest was performed as is shown there, showing bilateral infiltrates. He was admitted for management of hypoxia and shortness of breath. And you can see in the red arrow on top, the start of cycle 1, day 1 of the IDH2 inhibitor in his case. And you can see that really rapidly over a period of about 2 weeks, you can see cycle 1, day 15, his white count is markedly elevated. And you would initially be concerned that this patient could be progressing, that this could be some sort of rapid proliferative leukemia. However, you look below and the neutrophil count is increasing. So these are mature white cells that are developing with treatment on this IDH inhibitor. And so in patients who develop clinical symptoms of differentiation syndrome, on the left you can see a table of the common signs and symptoms consistent with differentiation syndrome. These include primarily culture-negative fevers, dyspnea, pulmonary infiltrates, hypoxia, effusions, as well as bone pain and rash in some instances. These occur in about 10 to 15% of patients who are treated with IDH inhibitor therapy. And on the right, you can see the treatment of presumed IDH differentiation syndrome, which is the most important part about treatment is early initiation of steroid therapy. And we use dexamethasone 10 milligrams twice a day. This is what is used in differentiation syndrome, which happens in patients with acute promyelocytic leukemia who are receiving therapy with ATRA. And it is quite effective in rapidly dampening down this differentiation syndrome. You can also start hydroxyurea if the patient has concomitant leukocytosis. You can give Lasix, furosemide, other supportive care agents if they have significant edema. And you can also stop the IDH inhibitor if the symptoms are severe. However, the half-life of these IDH inhibitors is quite long, 4 days or more. And so stopping the IDH inhibitor is really not the first line of defense against differentiation syndrome. You really want to be starting the steroids early. There are a few other important clinical pearls in treating patients with the IDH inhibitors, and one is the indirect hyperbilirubinemia that can happen in patients treated with Enasidenib. Actually a third of patients who are treated with Enasidenib do have elevation of the indirect bilirubin. So this is unconjugated, this is not intrinsic liver toxicity, and it's due to the off-target inhibition of the UGT1A1 enzymatic system. In these patients, dose reductions, drug delays are not typically required. Typically, you see the bilirubin rise up to about 3 to 5, and then it will actually seems to burn out over time. This effect is quite similar to Gilbert syndrome, which is a UGT1A1 deficiency, which of course is a genetic disorder affecting about 10% of the general population. And so this is just something to be aware of. If you see an elevated bilirubin level, you really want to make sure to review whether it's indirect or direct, and if it's indirect, it is most likely drug-related and not clinically significant, and you can continue treatment. Finally, it is important to note that there is QTc prolongation with ivosidenib. This is the IDH1 inhibitor. About 26% of patients on the original phase 1 clinical trial had any grade QT prolongation. Grade 3 or higher QT prolongation occurred in 10% of patients. Management on the original trial included dose reduction in 2 patients, dose delay or drug hold in 13 patients. No events were fatal or associated with cardiovascular compromise, such as torsades. And it is important to know that QT prolonging medications, such as azoles, fluoroquinolones, other antiemetics, were all allowed on study. And so in most cases, when you have QT prolongation, stopping those concomitant medications may be all you need to do, as opposed to holding the IDH1 inhibitor. But being aware of the QT prolongation and monitoring this is important in patients treated with the IDH1 inhibitor. In conclusion, ivosidenib and enasidenib are both well-tolerated oral agents. However, knowledge of the side effect profile is, of course, important for optimal patient care. Most importantly, you need to be aware of IDH-Differentiation Syndrome, which can occur in about 12% of patients. It includes fevers, pulmonary infiltrates, effusions, edema. It can happen anywhere from 1 to even 4 to 6 cycles in, although typically it happens around 2 cycles into therapy. And treatment includes the early initiation of dexamethasone. Also hydria if there is concomitant leukocytosis. You can hold the IDH inhibitor, but again, the most important thing to do is to start those steroids. Also, just to be aware that indirect hyperbilirubinemia can be seen with enasidenib and QT prolongation can be seen with ivosidenib. I want to thank you for your attention.